Welcome to Part 3, the finale of our Body CT On-Call series. This one's all trauma, starting with the solid organs, then bowel and mesentery, the pelvis, and the bladder. Let's begin. First up is splenic injury, the commonest injured abdominal organ, often with left lower rib fractures alongside. On a dual-phase CT, you're grading laceration and hematoma against the AAST scale. Grades 1 to 3 are the same two features, hematoma and laceration, in worsening degrees. The shift happens at grade 4, where you get vascular injury or active bleeding confined within the capsule, and 5 is the logical worst, a shattered spleen or bleeding beyond the capsule into the peritoneum. The delayed phase is the trick throughout. Contained vascular injury fades, active bleeding grows. The main complication to watch for is delayed rupture, up to 10 days out. The differential is arterial phase heterogeneity, where the spleen's mottled sinusoidal filling mimics a laceration. Confirm on portal venous. The spleen is preserved where possible with conservative management and follow-up, while vascular injury and active bleeding are taken for urgent intervention. On your report, give the laceration, hematoma, hemoperitoneum, and grade, and flag the delayed rupture risk. Next is hepatic injury, the second commonest, with nearly half having a concurrent splenic injury, so having found one, look for the other. The low grades are the familiar hematoma and laceration worsening, and the interest is at the top. Grade 4 is a quarter to 3/4 of a lobe disrupted or bleeding into the peritoneum, and 5 is more than 3/4, or the juxtahepatic venous injury, the retrohepatic IVC or central hepatic veins, which is the one that kills. The main complication to watch for is bile leak, so look at the duct. The differential is periportal low attenuation, which isn't always blood. It can be biliary injury or simply resuscitation overload. Biliary assessment is the priority, since biloma and bile leak delay healing and may need ERCP, while active bleeding is taken to interventional radiology. To recap, give the laceration, hematoma, and grade, and flag any bile leak. Renal injury is next, in 8 to 10% of blunt trauma, with flank trauma, deceleration, and lower rib fractures. The kidney adds a delayed excretory phase at 5 to 15 minutes if there's hematuria, provided it doesn't hold up emergent management. The low grades are hematoma and laceration worsening, as before, but the kidney-specific step is grade 3, where the laceration reaches the collecting system and you get urinary contrast extravasating on that excretory phase. Grade 4 is active bleeding or complete PUJ disruption, and 5 is a torn renal artery or vein. The main complication to watch for is the vascular pedicle injury, which carries the mortality. Two discriminators here. Urinary contrast on the excretory phase is dense and obvious, and a leak around the renal pelvis with nothing opacifying the ureter below points to a PUJ tear rather than a distal injury. A shattered kidney, active bleeding, pedicle avulsion, or urinary extravasation are taken for immediate intervention. On your report, give side, laceration length, rim distance, and grade, each kidney graded on its own. That brings us to pancreatic injury, which is rare but easily missed. On a portal venous CT with thin sections, you'll see a vertical low-density laceration, with ductal involvement likely once it crosses half the gland width, plus peripancreatic fluid tracking along the splenic artery. The neck is the commonest site, compressed against the spine in seatbelt injuries. The main complications are ductal injury, which can drive pancreatitis, then pseudocyst and abscess later. Most feared is an associated duodenal injury, which worsens the prognosis, so look for it. The differential is unopacified bowel or a normal cleft mimicking a fracture line, and post-traumatic pancreatitis giving diffuse swelling rather than a discrete tear. Duct injury, major laceration, and duodenal injury are taken for urgent surgical review. On your report, note whether the tear crosses half the gland width and whether the duodenum is involved. Next is bowel and mesenteric injury, the one that gets missed, off a lap belt, handlebar, or direct blow, and the signs evolve over hours, so an early normal-looking abdomen doesn't settle it. On a portal venous CT, reviewed on lung and soft tissue windows, the direct signs are a bowel wall defect or discontinuity from transmural injury and extraluminal gas indicating perforation. The softer clues are focal wall thickening, mesenteric hematoma and stranding, and unexplained free fluid with no solid organ injury. The main complications are peritonitis, active mesenteric hemorrhage, and bowel ischemia, where a mesenteric vascular injury has devascularized a segment. The differential is shock bowel, which presents with the classic hypoperfusion signs: diffuse wall thickening, a flat IVC, and bright kidneys, pointing to hypotension rather than perforation. Free gas, a wall defect, or unexplained free fluid with mesenteric injury warrants laparotomy, and active bleeding is flagged. Next is pelvic fracture from high-energy trauma with hemodynamic instability. On CT of the abdomen and pelvis, with CT angiography if bleeding is suspected, treat the ring as a ring. An anterior break through the pubic rami, then look posteriorly at the sacrum and SI joints, because two breaks or diastasis makes it unstable. Then look for contrast blush flagging embolization and note the pelvic hematoma. The main complications are bladder or urethral injury with anterior ring fractures, an unstable two-site ring, and the most feared is active arterial hemorrhage, the major cause of death. The differential is an old fracture with corticated margins, or a sacral insufficiency fracture in osteoporosis. Low energy, no major hematoma. Active arterial extravasation is taken for embolization, and unstable rings for stabilization, with bladder, urethra, and bowel assessed. On your report, flag the unstable ring and any active extravasation. Pelvic fractures bring us to the last condition, bladder trauma. The protocol carries the weight here. A CT cystogram with retrograde filling, because passive filling misses leaks, plus post-drainage images. Intraperitoneal is a dome rupture from a blow to a full bladder, with contrast outlining bowel loops and running into the pericolic gutters. The complication to watch is urinary peritonitis. Extraperitoneal, seen in pelvic fracture, presents with the classic flame-shaped contrast around the bladder base, and there the concern is a pelvic urinoma and sepsis. The pitfall is the underfilled bladder, which can hide a leak entirely. The cystogram only works if the bladder is properly distended. Intraperitoneal rupture is repaired surgically. Extraperitoneal is usually managed with catheter drainage, and the cystogram is the study that answers it. On your report, give the wall defect with extravasation, which compartment, any associated pelvic fracture, and assess for urethral injury. And that closes part 3, and with it, the whole body CT series. Thanks for watching.